Hello friends, Namaste. In last lecture about communication, we saw what are the characteristics of good communication in PC. And again we saw the importance of empathy in the communication. That was regarding basically about the communication, how it should be spoken to, how it should be heard to. Now we are just in this particular lecture, part 2 of the communication skills, we'll see the methods of communication. Basically there are two, we'll just see. These things we saw in communication in medical field very important, because all these 7 points I have written, communication is very important when you break the bad news. Your aim shouldn't be to shock the patient. How to break the bad news? It's a process by itself. You have to break the denial. You have to break the collusion. Difficult questions you have to answer. Patients are going to answer. Patients are going to question very difficult questions when they know that they have to face the death. There's lots of ethics and spiritual issues which need clarification by the patient, emotional reactions, bereavement. So all these issues where communication plays an important part. I just said that in this part of the lecture we are going to learn about methodology. How communication can be done easily. So in part 3, actually it's the part 1 of this lecture, but I am going serial wise, that in part 1 of communication, this is part 2 of communication, so this is part 3. We are going to discuss a 6 points toolkit. This particular tool, if we use, our communication can be improved. And in last part we'll talk about class protocol. Which are the 6 points which need real and very precise, what can I say, it should be attended to. If you attend to all these 6 points, your communication will be of superb standard with the patient. First is comfort, language, question style, active listening, reflecting and summarizing. Let's see in detail. In communication with the patient, you should be prepared to stop the interview at any stage. When you are talking to the patient, a stage may come that you might have to end it abruptly. Repetitions of questions will be there for silence, for denial, for emotional reactions. The patient or family members are going to show all these things. Therefore, from the very beginning, a doctor needs to be prepared with such situations. Comfort. First point, preparation, physical environment, sitting, perception of time spent, height of chairs, eye contact, all these things. That is total arrangement. It must have privacy, it should be in a room. Communication with the patient cannot take place in a corridor. The physical environment should be there. Sitting, a doctor is sitting and the patient is just standing and asking questions. No, nothing doing. This cannot happen. A patient also must sit. If family members are there, they should be given proper stools or chairs. That whole environment should be comfortable. The patient should be looking into the eyes of doctor and doctor should be answering it. And therefore, height of chairs should be arranged in such a way that there is proper eye contact. When you start the conversation with the patient, make sure that the conversation carries on without any interruption. Particularly, make that mobile and other things, if possible, should be kept under silence mode. Privacy is very important because most of the patients, they feel shy. Anybody, if I have to talk about my weakness, I will feel shy. Therefore, it is important that the patient is being given proper privacy. The interview should be conducted in the room itself, and the doctor must introduce himself or herself, may shake hands, sit down, make eye contact, avoid medical jargons. So this is the initial part of complete interview. When I am saying interview, it's understand interview means the dialogue between patient and doctor. That is what I call an interview. Second, language. Engaging and gently transferring the information. Do not rush the patient. Can you come on, tell me hurriedly, I have got just 2 minutes to listen to you. No. This is not the way a doctor will ask a patient to say. A patient will take his own time. He is a sick person. He is mentally disturbed. He is feeling shy. Therefore, give him enough time to speak, Give enough time. Avoid complex words. We said in last lecture, I said the language should be simple. Do not use any medical jargons. Jolling along, this will happen, Do not. Let him say clearly, and let doctor should also say clearly. There is no requirement of going along with each other's feeling. Jargon, particularly medical jargons, should not be used. Nobody understands it. Only doctors understand that language. A patient coming from villages, otherwise also everybody is not a doctor. So when you talk to a patient, you speak that language. You want to explain the name of the disease, the symptoms and everything in simple words which any patient can understand. Question style, question should be open. Open question means what, how, that means they are answerable questions. Questions that start with did, do, would, will, should, could, have, must, these are all closed questions. Closed question means either answer is yes or no. Did you eat your breakfast? The answer will be what? Yes or no. Specific question means which intends to receive specific information of a particular problem. If the doctor is asking, did you have fever last night? A specific question. Did you have a fever last night? Yes or no. If yes is there, then the dialogue will continue. Visionary means talking about future and other things, What are your dreams? Tell me more. Particularly, visionary questions will be asked to the people who are in the last stage of the life. What will happen? What will you do? What should your children do after you die? All those things about future. I have given very simple statements, simple sentences to understand. Open question. Example, how do you feel now? When I ask you how do you feel now, a doctor asks the question to patient, patient can answer in any way. He is open and actually he will narrate how he is feeling. He will say, okay, I am feeling very fine, doctor. I have taken medicine for 2-3 days. I am feeling little bright. He will give out the total description how he is feeling. Therefore, it is called open question. To elicit information from anybody, you should always ask open question. Then only the person will be able to give the answers to you. Okay, this is what I have done. If you ask a person another open question, general open question, what did you do last night? Now that person is open. He will ask, yes, last night I did so many things. 3 o'clock, 4 o'clock, 5 o'clock. Everything will say. But if I ask you, did you have dinner last night? Answer will be either yes or no. So, open question gives lots of chances for giving and receiving the information, and particularly between doctor and patient's relation, doctor wants to receive more and more information from the patient. Similarly, patient also wants to receive the information about his state of health. Close question, how is pain in your hand? You will just only 2 words are there. It is okay, ya to bad pain. One should not ask a closed question. Focus question for a specific information. Like I said, okay, did you have any fever last night? Did you take proper medications last night? Leading questions never ask. Direct question eliciting a special symptom, yes, you can ask because you want a particular information about a symptom. This is symptom. Multiple questions will be asked in the first interview because you want to collect all the information available about the patient, family, and the state of disease. You want to write down the full case history. You want to find out what is the diagnosis, and therefore lots of questions, multiple questions will be asked. So this is all about question style. This is what we had been generally making use of in your social life. When a college friend asks the college friend, he'll be generally asking the open question. Okay, what happened? What did you do last night? How was the movie last night? This all because they want to collect lot of information. They want to remain in touch with each other. Eliciting feelings and distancing. Eliciting means asking for information. Distancing means I don't want your information. Leading questions tend to produce the questioner want to hear. Are you feeling better today? Leading question. So some patient might say, yes, I'm feeling better. Closed questions, have you any pain? Yes or no. Common ways of distancing. Distancing means to get away, you don't like him. It's a sort of, in a way, sort of behavior with apathy, Non-verbal messages, labeling, paying selective attention to safe physical aspects, never asking beyond the physical. Never asking beyond the physical, that is called way of this. Why? Doctor is supposed to be little social also, psychological also. We are talking palliative care, we are talking about holistic, everything. Physical, mental, social, spiritual. So it is not only about the pain and the disease the doctor need to ask. Doctor need to ask about the family. What is going to happen in details. Premature normalization, false reassurance. Doctor is not supposed to false reassurance. Okay, yes, things will be okay. No, doctor is not God. But he has to be hopeful. If he complete this particular course of medications, yes, possible. We'll see better result. Inappropriate humor, you should not. And disappearing from stressful situation, sometimes you get away from the discussions not done by the doctor. I said case history is very important step in medical process, and it is the first step. History means it is his story or her story, and therefore in writing case history, communication will play an important part. We need to know his issues in order to help him. Listen to the story therefore. Active listening is the key to effective communication. How do you carry out active listening? Open questions, because in open questions you receive a lot of information. Accept silence. Silence is also part of communication. When a doctor asks 2-3 questions and the patient or the family members who do not speak, they maintain silence, that means yes, they are trying to assimilate the questions. They want to give proper answers. They want some time to react. So accept silence in such interviews. Avoid unnecessary interruptions. Respond through verbal and non-verbal means. Make use of verbal as well as non-verbal means. Do not close your eyes and discuss. Summarize and prioritize the agenda. Empathize. Summarize is summary. Once the whole communication between patient and doctor is over, that interview, then summary should be given to the patient. Yes, this is what has happened. You are suffering from this and this, and the probable diagnosis is this, and this is the plan of treatment. This is what we are going to do. 1, 2, 3, 4. So the whole summary should be given to the patient, and then just give hope. Yes, in such cases, I have treated many cases and had been successful, doctor will say. So we'll go accordingly, and things will be okay. Listen, listen, and listen. in active listening, you concentrate fully what is being said rather than just passively hearing the message of the speaker. It is, yes, you do hear the message, those words part of it. But what is being said, what is the psychology behind that? What are the feelings behind that? That also should be understood, and that can be understood provided you listen actively. Active listening signs, you smile, eye contact, posture, mirroring, distractions, these are the most basic and powerful way to connect to another person is to listen. Listen and listen. Just listen. Perhaps the most important thing we ever give each other is our attention. When you are listening to somebody, you are giving your attention to somebody. A loving silence often has far more power to heal and to connect than the most well-intentioned words. You just listen, maintain silence. You just be there in the room with the patient. Maybe you take the hand of the patient in your hand. That is all a patient requires. Reflecting on the answer, think over, yes, you said this, I understood, but what should we do now? Correction of misinformation should be given out. And summary, I said, very important, so that both the parties, the doctor and patient, they know where they stand, what is to be done next. Communication problems, bad news, denial, collusion, this is where we are going to face. Now, there is a class protocol in last part of communication process. First, let's understand what is a protocol. What is a communication protocol? A communication protocol is a system of rules that allows two or more entities of a communication system to transit information via any variation of a physical quantity. When two entities, that means here in our case a doctor or patient, they are transmitting information. Sometimes doctor speaks, sometimes patient speaks. How they should talk so that the physical whatever information needed to be conveyed can be conveyed and should not be left out. So there is a well format protocol, because this is how, if you do it, that communication will be complete. So here we have a class protocol. The patient first meets a palliative care professional until the last moment of life. When such communication takes place first time, this communication has got two types of meaning. Any communication between doctor and patient, it has got two meanings. First is that communication bears the news that this is what is happened. It is basically about the person, about the patient, and a little bit about disease. And the second part of that communication is the supportive dialogue. Therapeutic, yes, this is what has happened with you in last 6-7 days, dysentery, diarrhea, this or that, and this is what we have done, fine. Second stage, now what should we do? It should supportive and therapeutic. What is the treatment plan? So such communication have got two meanings, bearing the news and therapeutic or supportive dialogue. CLASS is an acronym. C stands for context. Context, I said, the setting. What is the setting? How and where the interview is taking place, which room. L means active listening. A means acknowledge emotions. Acknowledge emotions of the patient. Management means what is the strategy, what is the treatment plan, how that particular disease needs to be treated, and last S means summary. This is the class protocol. When you carry out first interview with the patient, then this is what you will follow. Methodology. Take home message, genuineness, based learn through experience. Identify your skills and try to refine them. Identify your shortcomings and try to overcome them. In communication, there are no rigid guidelines. It depends on basically the doctor and the patient and the circumstances coming up. Should be person centered and context oriented. Do not try to imitate someone else. Only two parallel principles are there. Never lie to a patient. Never lie to a patient. If there is a bad news to be given to the patient, break it properly. Do not give a shock and numbness. There is a proper procedure to break the bad news. And second, avoid thoughtless candor. Means be very gentle. Do not be dumb with him. Do not rush the affairs. So whenever you talk to the patient, always talk with empathy, as if you are feeling the same pain what he is undergoing. 10 commandments. A good communicator is not one who is perfect and therefore never commits a mistake. There is nothing like perfection anywhere. Nobody is perfect. There is no perfect good communicator. So he is one who tries and gets it right as often as possible. But who is the good communicator? He finds out where and how did he commit the mistake and how he is going to improve upon the mistake. In normal interview with patient and doctor, both will speak, not only doctor. Thou shalt not force your convictions on the patient. Whatever you may know about that particular disease, but do not force your views on the patient. Patient has also the right to say something about it. Do not make assumption that this may have happened. No. Medicine is a science. There is no place for assumption. If you think something has happened, then there are lots of medical tests, this or that, Thou shalt not be patronizing. You should not patronize. Patronize means, no, I am there with you, I look after you. Nobody looks after no one. Just be very, very frank with him. Be gentle. Yes, this is the situation and we'll do like this. Thou shalt not moralize. Do not give moral lectures. Okay, don't worry, you are not the only one suffering from. There are so many people who have suffered. So many people had the heart attack. No. Never draw comparison, particularly maybe about the disease and other things. Everything is different. Every patient is an individual and the disease what he is undergoing is also totally different from any other disease. No sympathy. I'm sorry, I'm really very sorry. This is what has happened. As a doctor, you had been seeing so many patients since last so many years. So you have to be sympathetic, but there is no requirement of showing it too much. No use of medical language. Whatever is required, give it out in simple language which the patient and the family members can understand. Avoid lies. Don't tell lies. Be frank with him. Be honest. And last, do not make use of inappropriate humor. Humor is very fine. He should be jovial, but wherever a serious situation is there, and particularly sickness is a serious situation. Sickness is a serious situation for the patient and for the family members. So there is no place for inappropriate humor. Techniques to improve palliative care communication. Sit at eye level. If I am the doctor, then the patient also should be sitting at the same eye level so that I can look into his eyes and he can look into my eyes. Be focused on the patient. When the patient comes, he is the only guy you are supposed to talk to him. He is the only person. Total concentration on the patient. Make eye contact. Speak in short sentence. Do not speak long sentences. Use simple language. Use drawings and pictures. You have lots of models and other things to explain. Like if you go to a dentist, dentist will just take out the models of dentures. Because this has happened to your upper teeth and lower teeth, So if possible, doctor should keep some models and charts and must explain to the patient. Ask the patient to describe his or her understanding of your explanation, and let the patient describe, so that you will, as a doctor, you will come to know how much understanding he has, and whenever you decide upon the treatment plan, how much understanding he will require. Give a written summary of recommendation. That is, of course, medical's part. You must give out the written summary. This is what has happened. This is the case history. This is the probable diagnosis. If more tests are required, and all those things must come out properly. Gentlemen, dear friends, here we come to the end of first week. First week is very important because here we are trying to introduce this new subject to you, and it is about integrative palliative care. Very important subject. As we said earlier, it is for everybody. It is for a lay person also. It's not that nurse or doctor can do it and can understand. We have made this particular course in such a way that anybody who is interested and can understand English can do this course and can understand it properly, can digest what we are going to speak and what we are going to say. And I'm certain that it will be useful to them, to their family members and lives. In this particular week, we had number of lectures. We started with what is palliative care. Dr. Geeta Joshi explained all those things, and then thereafter we came to the main subject, integrative palliative care. What is integrative palliative care? And then we explained everything about CAM, complementary and alternative medicines. After that, two most important aspects were there about palliative care. First was community participation, because without community participation, we cannot practice palliative care at all. We need the support of the patient and his family. In palliative care, patient is at the center, not the disease. And when the patient is at the center, we need the family and the whole society, the community to be the part of palliative care. So we spoke about community participation, and then we came to the communication. If there is no communication, we can't do anything about it. In any other medical stream, fine, doctors may not do it, but in palliative care, particularly when you are dealing with communities, your communication skill should be perfect. So we take sufficient time to tell you how and what are the characteristics of communication, plus the methodology in which we give you 6-point toolkit, and finally we discuss about the class protocol. Thanks.